All right. So I'm the last of the show. So I'm Amy Jernigan. Again, I'm a gynecologic oncologist and associate professor with LSU Health in New Orleans, the medical director of cancer services at UMC, and then the chair of the cancer service line with LCMC Health. So today I wanted to take some time. Clinical trials are something I'm very proud of and passionate about, and I'm very proud of what our team has been able to accomplish. Our team being like the international, national GYN oncology community, our team here in New Orleans across institutions, and then our team with LSU LCMC Cancer Center. And I thought it would be fun because this is the way I learn about new drugs, new techniques, new, treatment paradigms, and how I remember some of these very high-level, sophisticated things is I usually have a patient attached to them. So I wanted to tell some success stories and just some individual stories that come from actual patients here in the greater New Orleans and South Louisiana area. And then talk about some of the exciting trials we have on the horizon. Science is moving extremely fast, and we've got a lot of great stuff coming. And then talk about some of the innovative programming we have designed to ensure that we have access to clinical trials for all of our patients. So we're putting women on trials right here. So an immunotherapy trial was my gateway drug. I started here 10 years ago. And one of the earlier trials we opened up was NRGGY018. Our OG regimen for advanced and recurrent endometrial cancer at that time was carbo and Taxol. That's what we were giving everyone. And really, if you had stage 3 or 4 recurrent endometrial cancer, like, you were lucky to be alive at a year or two after that. So most people eventually failed, and then, and then there was not much else to treat them with. And so this was cool. It was a placebo-controlled trial. We put a number of patients on, and then eventually they unblinded it. And we had some women who did extremely well, which I'll tell you about. And since then, immunotherapy has kind of become like the Frank's hot sauce of basically taking care of patients with cancer, where everyone's using it in every disease site, it seems. So this was a really great trial. One patient we put on it was, the reason I have the little goat up there, was a 70-year-old Tobagan woman. She always cooks. She's one of my partner's patients, and she always cooks like a whole goat and brings the goat into clinic, which is really nice. But she had a high-grade cancer in 2021, high elevated CA-125, CT scan with basically carcinomatosis and a large uterus. And she was debulked, but still had some measurable disease post-op, and she was consented for trial, was started on carbotaxol and either pembro or placebo, we didn't know at the time, and was treated from August until November of 2021 with a complete response, and then went through maintenance with, again, placebo versus pembro. We eventually found out it was pembro. She did really well until she progressed in December of 2024, where we added lenvatinib to that pembro. And she did very well on that until most recently, just summer of last year, when she started in HER2. And then this was my personal patient, and she was a teacher and no-nonsense lady. And she came to us. She had been initially treated, not by me, but by another colleague in our system, who diagnosed her with endometrial cancer. She had a radical hysterectomy, BSO, lymphadenectomy for stage 2, MMR proficient uterine serous cancer, and then recurred in February 2022. She had this big mesenteric mass and a huge left lobe mass in her liver. Biopsy confirmed that it was a recurrent uterine serous carcinoma. We enrolled her on trial. Again, carbotaxol, pembro versus placebo. We weren't sure at the time, although it ultimately ended up being unmasked to be pembrolizumab. And she did that all the way through until protocol completion in January 2024, and then has done nothing since, and has had, you can see here, the liver mass she presented with is on the bottom screen there. I don't know, my cursors are a little off, sorry, and then the top of the screen is where she ended up after all that treatment, and nothing really moved. So she did very, very well. And this is just some information from the publication of that trial, showing that pembro added to carbotaxol improved progression-free survival in both deficient and proficient MMR populations, with hazard ratios of 0.3 and 0.54 respectively. So really impressive results. And this trial doesn't stand alone. The Ruby trial was the trial with dostarlimab, basically the same trial, slightly more widely included patient population, so including things like carcinosarcomas and things like that. And again, showing very similar results. Dostarlimab showed a 70% risk reduction of progression and death in the deficient MMR groups. And then we have the DuoE trial, which was also really interesting, that used durvalumab, and there's also a component of adding olaparib to that durvalumab, and that's a separate discussion, but also showing a benefit of durvalumab in the dMMR patients. And all these trials did show PMR groups benefiting, but not as substantially as the DMMR group. This was a very lovely patient of mine that came from all the way from West Louisiana. And she had a hysteroscopy DNC in November 2018 that showed grade 3 endometrioid adenocarcinoma and then had hysterectomy BSO vaginal cuff brachy, and actually ended up getting genetic testing and was found to be BRCA1 mutant, which anecdotally, I feel like I have more BRCA1 mutant endometrial cancer patients than ovary for some reason. I'm not sure what that's all about, but definitely happens. And then she ended up in September of 2021 having a blood clot, carcinomatosis. They biopsied it. It was a recurrence of her endometrial cancer. And she was treated at that time with carbotaxol and then olaparib maintenance based on that BRCA1 mutation. And it did well until she had progression of disease in April 2023 and got len-pem at that time until progression in November of 2024. So did well for quite a while. And we enrolled her on the Acrivon trial, which I'm pretty excited about. We've had open at our site, and we've enrolled to quite well. And she got treated with a very ultra low dose gemcitabine, and I'll explain what that means in a minute, and then this novel agent, ACR368. And so she did very well. She had an initial partial response, and then eventually had a slow progression of disease in November of 2024. So she did well for about a year on that regimen before being put on letrozole and ribociclib, which she actually responded to as well. So this trial is really kind of cool. So basically, DNA replication in cancer cells is accompanied by stalling and collapsing of the replication fork and signaling a response to DNA damage and premature mitosis. And that's called replicative stress. And sort of in simple terms, what happens when cancer cells are dividing very quickly is they start running out of the building blocks to make new DNA. And so there was this OncoSignature test where we would biopsy the tumor, and if it comes back positive, that means the tumor already has replicative stress. And so the idea is if it already has replicative stress, this ACR368, which is a different kind of checkpoint inhibitor, it's also a checkpoint inhibitor, but not the immunotherapy kind, which is very confusing. And I'll explain that in a second, but you can apply that and it should work. And then if the cell is replicative stress negative, and this was what we liked about this trial, is that you could actually induce it. And the dose they actually landed on to induce it, and for those of you who give gemcitabine, it's like 10 milligrams per meter squared. We usually give doses of about 1,000. So it's a very, very, very tiny dose of gemcitabine. And when you think about how gemcitabine works, it kind of subs in as like a fake nucleotide in the DNA. And basically by doing that, it creates this replicative stress environment. And so I have some this was just presented at ESGO and it was available online, so I stole the slides. But basically, this is their results. And you can see that it's a highly diverse patient population. Uterine serous carcinoma was the most common. Most of the patients were mismatch repair proficient and P53 mutant. And most patients had seen prior IO before, and just shy of half had seen len-pem previously. So this is the OncoSignature positive arm. So these are the patients that had biopsy-proven tumors to have replicative stress. So all they got was this novel agent, ACR368, which, sorry, I should go back to this. On the bottom, you see it's it basically, the way the ACR368 works is it impairs the cell cycle checkpoints at between, G0, G1 and S, and between S and G2, which basically means that it's sort of counterintuitive, but you would think we would want to prevent cells from dividing, but if these cells are messy and sloppy because they have replicative stress, if you just let them blow through those checkpoints without repairing things, they basically become so unstable, they collapse. And so we can apply that. So these are the patients that already had replicative stress and got that agent alone, no gemcitabine. And you can see that, there's about a 39% overall response rate, which, to be honest, in recurrent uterine cancer in and of itself is pretty good. But there's also a disease control rate of about 80.6% and a clinical benefit rate at 16 weeks of about 61.3%. This isn't so crazy, but if you had only seen two or less prior lines of therapy, you did better. And that's something you'll see a lot in things. What was really cool, and this is really where things are going now, is that in the serous all-comer group population with less than 2 prior lines of therapy, they really saw some impressive response rates. So these patients, these are all comers. So some of them got ACR368 and some of them got the ultra low dose gem and ACR368. But the response rates were about 52%. The non-serous, it was like 22%. So And we've had a number of patients in both groups, and I'll say that we've seen some people with some very stable disease for a long period of time, but we have seen serous patients really respond quite well to this agent. So right now we're really focusing on this biopsy independent group, which is great because they don't need to get a biopsy at all. And if you have recurrent uterine cancer after carbo or platinum-based chemo and some form of immunotherapy, then you can move on to this arm and you get the ultra-low dose gemcitabine and the ACR368. And this is really important because uterine serous carcinoma is responsible for 40% of the deaths, even though it's not the most common endometrial cancer. And most of these patients are going to need a second line after platinum-based chemotherapy and IO, but response rates have conventionally been approximately 15%. Progression-free can be quite low, about 3.5 months. And while HER2, there's some really great new anti-HER2 strategies out there. Only a few patients can get that because you have to have HER2 positivity. So we still have a very big unmet need in that population. So this is a patient of ours who presented with left axillary lymphadenopathy, and she was found to have advanced endometrial cancer. One of our colleagues who just gave a talk was kind enough to share her with me after she had a recurrence. And we enrolled her in GOG 3095, which I want to talk to you a little bit about, but unfortunately she got in the investigator choice arm. And then in September of 2025, she enrolled in our A-Link trial, which is a first-in-human open-label multi-center phase 1/2 study evaluating a novel antibody drug conjugate in patients with advanced solid tumors. So GOG 3095 opened and closed very quickly, enrolled in really well. And this was a phase 3 randomized control trial of sac-TMT versus physician's choice for chemo for advanced endometrial cancer. And basically, it's an antibody drug conjugate. And so for those of you who don't know what that is, I describe it to my patients as putting glitter on glue. Essentially, it's an antibody that sticks to a specific receptor, in this case, the TROP2 receptor on the surface, which is widely expressed on cervical and endometrial cancer cells. And it has a topoisomerase inhibitor basically attached to it. So I always tell my patients I could cure their cancer if I wouldn't kill them with the amount of chemo I would need to do. Essentially, it's like smart bombing the tumor. So giving really, really high doses of chemotherapy to the tumor itself and then limiting that toxicity to normal tissues that don't express the TROP2. There was in the phase 1/2 study of that, there was a dose of 4 milligrams per kilogram, and essentially there was a response rate of 31 to 34% in both the 4 milligram and 5 milligram arms. And side effect profile was a lot of things like hematologic toxicity, some mucositis, things like that. Unfortunately, she got the Taxol arm, so she did not get put on that study, but we do have the sister study to that open in our institution in cervical cancer, and we're looking forward to seeing the results of 3095. So the A-Link trial, which was what was really cool for her, Dr. Tang joined us a couple years ago and set up a phase 1 clinical trials unit, and has really plugged and played really nicely with our GYN cancer group. I think our patients, we proudly put about 20 to 30% of our GYN cancer patients on clinical trials. And so they're very warmed up to the idea by the time they get to phase 1 territory. And so again, for most of you know, but phase 1 means that these are like first in human studies. So you have to be kind of warmed up to that concept to go there. But we've had a number of very highly motivated patients, and we've had some excellent colleagues like Dr. Hamilton and Valente and such that have kindly shared their patients with us. And just because these trials have been great. So ALK 201 is a novel high affinity FR2 beta targeting antibody. And it's an antibody drug conjugate, and it's stuck to a topoisomerase inhibitor. And so this patient went on that trial, and you can see when she had been on 3095 with me, she had stable disease for a while, and then she just developed this left parasternal mass that was, you could see it across the room. It just was like 6 centimeters. It was huge. And then you can see on the right what she did, and it got down to about 3 centimeters. Same trial, different patient. This is a 25-year-old woman with a rare cancer, which is another really great place to have these phase 1 trials, because as we all know, it's not rare to take care of rare cancers, but there are a lot of them. And so I can't have a clinical trial open for every rare cancer that exists, because that's just prohibitive. So this lady had a laparoscopic cystectomy and was diagnosed with a juvenile granulosa cell tumor. These are extremely rare tumors, about 0.4 to 1.7 per 100,000 women. Granulosa cell tumors themselves are rare tumors. These are less than 5% of granulosa cell tumors. So they're very rare. I think I've taken care of 2 in my entire career, okay? She was pregnant. She got the treatment that these patients usually get, which is there's no real standard of care because no one knows what to do. There've never been more than like series of 5 or 6 or 10 at a time. So nobody has a lot of experience. And so we do what we usually do for ovary and GYN cancers. We throw carbo and Taxol at them, which is totally appropriate. It's what I would do. And she kept recurring essentially. And she's like a young mom. She's like having babies through all of this, which is wild. Anyway, she came and saw me with a pelvic mass and wanted to know what I thought she should do. And I was like, I have no idea. No one knows what you should do. And fortunately, Dr. Tang had this A-Link trial open, and we did have a path review, and they suggested that it might not be a juvenile granulosa cell tumor. It might be a steroid cell tumor, NOS. It really doesn't matter. That's also an extremely rare tumor. And so we don't have a standard for that either, but both are stromal cell tumors of the ovary. And she got put on the A-Link trial and has had a really impressive partial response. So this 6-centimeter tumor is now like 2.8 by 1.2 centimeters in her pelvis. And she's doing great with minimal toxicity. And again, this is a young woman with a kid. So it's potentially, hopefully, durable therapy, which is just really great. CS is a patient of mine who had a recurrent KRAS wild-type low-grade serous ovarian cancer. And we put her on Veristem's trial RAMP 301. So she, in July of 2015, had a HIS-BSO and debulking for a low-grade serous ovarian cancer, was treated with carbo and Taxol at that time, and then recurred. She went back to the OR for a cholecystectomy with GenSurge. They took out her gallbladder and then debulked some of her disease, but she still had a lot left in her abdomen and pelvis, and that's when she came and met me, was after that. And we treated her with carbo, Taxol, and bevacizumab maintenance. She stopped in May of 2024 with the bevacizumab maintenance, and then in January of 2025 developed progressive disease, enrolled in RAMP and was randomized to avutometinib and defactinib, which I'll talk to you guys about, and had a nice partial response to that as well. So if you don't know much about low-grade serous ovarian cancer, it's actually quite a distinct entity from high-grade serous ovarian cancer. The pathophysiology is different. The behavior of the tumor is different. Cytoreduction is everything, and it doesn't move very fast, but it also doesn't respond really well to a lot of things we throw at it. And so avutometinib and defactinib together work in a really interesting way. Avutometinib is a first-in-class oral RAF and MEK clamp, and it inhibits MEK kinase activity while also blocking compensatory reactivation of MEK by upstream RAF. And then there's this pathway sort of to the far right that you see through FAC that basically is like a roundabout way that the tumors kind of compensate when you typically block the RAF MEK clamp. And so you add the FAC inhibition to that and you get more impressive activity. So the bottom waterfall plot is showing you data from the RAMP 201 study, which was the phase 2 study looking at avutometinib versus avutometinib plus defactinib, and basically selected the combination as the way to go forward. It was really impressive, and there was a more impressive response rate with KRAS wild type and with KRAS or with KRAS mutant than wild type, but you can see there's activity across the board. So this clinical trial is what we opened, and we were very excited about it. And put a number of patients on it. And even though I can't have a trial for every rare tumor, I would say I really enjoyed having this trial open because I felt like even though low-grade serous are rare, the patients really came out of the woodwork for this one, which was great. And they got randomized to avutometinib and defactinib versus investigator's choice chemotherapy. And the ones that got investigator's choice chemotherapy had the option later to, if they progressed, to cross over to the investigational arm, which was a nice option on this trial. They recently narrowed it down to wild type only, and now they've even more than that actually limited it to only KRAS wild types, and they only want patients with elevated liver functions, which is really interesting. I can't find those patients, but it's almost closed, I think. And then basically she's had an ongoing durable partial response. And so we're very excited about that. And it's just nice to see patients respond well. So with regards to rare tumors, I think this is really where clinical trials pack a punch. We're really just pulling out of a grab bag most of the time for these patients. It's very hard to study these tumors. It's very hard to fund, run, and complete these trials, especially for the very slow-growing tumors like granulosa cell tumors and low-grade serous. And then the business incentives are really lacking. I mean, who wants to have a blowout drug for something that only 0.4 in 100,000 women get? not many people. But having a rare cancer is not a rare event, and commitment to studying these requires vision and commitment on behalf of the institutions as well as industry, and then the NCI and other things. So targeted and precision medicine strategies and advances in AI, I think, are going to be the two of the biggest things that will help us tackle this. I think a lot of these rare tumors are, once you can throw them through some next generation sequencing, you'll have targets and things you can tackle them with, and you can group them with stuff. And then AI, of course, is helping us data mine all this information. And this is an 80-year-old woman, and another one I shared with Dr. Valente, who had a laparotomy for diverticulitis and was found to have ovarian cancer. Colorectal surgery, gynonc, did a big combo case, cytoreduced her, and she got carbo and Taxol and then a laparib maintenance. And then in June of 2024, she progressed and was treated with carbo, gem, bev, and bev maintenance, and then had progressive disease and was now platinum resistant, was treated with mirvetuximab, which is our first antibody drug conjugate in the ovarian cancer space that targets the folate receptor, which was very exciting. And then in October, she progressed and we treated her on the Rainfall trial. She was treated with Rina-S. Her CA-125 went from 82,000 down to a nadir of 2,000. Her target lesions did also respond, and she had a 64% reduction from baseline. She ultimately had a partial response. So these are her imaging showing that partial response. And then this is Rainfall 1, which was basically the trial that informed the Rainfall 2 trial that we had open. And what it is it's a phase 1 study of these medications. And you can see that you can see the impressive response rate. So, and what those little pink versus blue bars is whether or not patients were folate receptor alpha positive or negative. And there's activity even in the folate receptor negative group. And I think that's what's really interesting here. And it can follow mirvetuximab. So I think, even though both mirvetuximab and Rina-S are targeting the folate receptor alpha, they're linked to very different chemotherapies. So mirvetuximab is linked to DM4, which works on tubulin inhibition, and then exatecan is a topoisomerase 1 inhibitor. So they're different chemotherapies, same target, and they can chase each other. So it doesn't necessarily mean that if you use one, you can't use the other, or vice versa. But in this phase 1 study, it showed really impressive activity. And so based on that, we went ahead and tackled that. Now, there was an endometrial cancer cohort we're really excited about. And at a median of 1 year, there was a deep and durable response to Rina-S as well, with an overall response rate of 50% and a disease control rate of 100%. And so we're excited because we're about to open up there's like 6 rainfalls. I think it's Rainfall 3 or 4. One of them is for endometrial cancer, so that's about to come. So what's next? So these are our little clinical trials maps that my partners and I use when we're organizing what we're doing. And I've talked to you about a number of these trials already, but just some commentary on the importance of cooperative groups and the teamwork that goes into that. GOG 3088 is leiomyosarcoma study, rare tumor. So we need the foresight of these organizations. NRGGY032 is actually a de-escalation study. And I think this is one of the things that concerns me the most about national funding through the NCI and things like that being potentially cut is our industry partners are going to come up with cool new toys, which is awesome. But we need somebody to help us figure out how to rein that in. And that's really where national funding, I think, comes in, and these NRG cooperative groups come in. You've got NRGGY035, which we've just opened, which we're very excited about, and that's for P53 mutant advanced or recurrent endometrial cancers, and it's carbotaxol bev, carbotaxol pembro, or carbotaxol pembro bev, and that's Dr. Fader's study. And then Rainfall 3, which is going to be the Rina-S in the endometrial cancer space. And we do still have, it's called Durafac, which is basically the same thing as RAMP, or the same combination as RAMP, but for KRAS mutated any other cancer other than at low-grade serous ovary. So we've been enrolling to that well. In the cervical cancer space, there's NRGGY037, which we're very excited about. Essentially, 2 big studies hit about the same time. There was the Interlace trial showing neoadjuvant chemotherapy would help improve progression-free and overall survival in patients who are getting cis-RT and brachytherapy for locally advanced cervical cancer. And then we had the Keynote A18 study, which showed that adding pembrolizumab to cis-RT and chemoradiation and brachytherapy for locally advanced cervical cancer improved survival as well. And so now the question is, should we do one or the other? Is there a way to combine them? This study is kind of clever. It's basically the KEYNOTE-A18 regimen versus that with some lead-in neoadjuvant chemotherapy. So that'll be a fun one to have open as well. Again, Durafac's open in that space as well. And the GOG 3095 sister study, GOG 33-101 with the antibody drug conjugate against TROP2 is open in that space as well. In epithelial ovarian cancer, we have a number of frontline studies. HOT is a HIPEC study. 3115 is looking at combining mirvetuximab, which is the antibody drug conjugate against folate receptor, with carboplatin. GY036 is another de-escalation kind of study. It's olaparib for 1 versus 2 years, and plus minus investigator choice of Bev, so potentially helping us answer 2 questions, although really just 1, but hopefully 2. And then Rainfall of 4 is replacing Gloriosa. Gloriosa was a very popular trial. We actually, I think, both had it open at both Ochsner and at LSU, but essentially it was adding mirvetuximab and Bev versus Bev alone maintenance in folate receptor alpha positive recurrent platinum sensitive ovarian cancer, which I know is a mouthful, but a Rainfall of 4 is going to replace that, and that's going to be using the Rina-S agent instead. So that'll be really interesting. And then we, of course, have we had Rainfall open for platinum-resistant ovarian cancer, and that enrolled faster than I think I've ever seen anything enroll in my entire life. And we're getting Catalina, which is going to be a CDLN6 antibody drug conjugate study in the platinum-resistant ovarian cancer space. So we're excited. I wish I could explain to you. My entire fellowship was I feel like every study was, do we give carbo and Taxol weekly or every 3 weeks? And do we give radiation first or after? And it was just very repetitive. And now we actually have a lot of stuff to play with, which is really great. And then there's enhancing access for Louisiana and the Gulf South. And I think the first and foremost thing I think I would have to say is that we're very lucky in this, our GYN oncology ecosystem here is a very friendly, collaborative one. And I think that's the best possible thing for our patients. So I really appreciate this community. I think it works in the best interest of our patients. Sometimes our patients really have a lot of odds against them. Something I'm very proud of is our Rare Camellias program. And so essentially, we had a number of patients with cancer who were being seen in Lafayette. And Ochsner has recently jumped in to fill a very needed burden there because there's just nobody physically there all the time. But for the last several years, there was no one, and we have an LSU gyn who is out there who was sending us a lot of patients. So we came up with the Steel Magnolias program, which essentially allows for virtual hybrid visits. It was spawned by COVID. And then we realized that we had a number of patients who were candidates for clinical trials, especially really simple surgical clinical trials. So we had this one NRG-CC010, which is a sentinel versus full pelvic node dissection study done through the NCI. And essentially, they would come to us for surgery, and they can do all their follow-up at UHC in Lafayette. And one of the things that's very cool, there's a poster about it here, and we're going to be presenting it as well at SGO, is that we have very, very low deviation rates, actually lower deviation rates in our Rare Camellias group than in our patients that standardly follow us. And I think that's probably because we have this mechanism in place, and it's not such a burden for them to see the gynecologist close to home in Lafayette, but we have other patients that come from afar, and we don't have that mechanism in place. And it is a lot to ask somebody to come back every 3 months so I can measure their legs or whatever it is. So we're very proud of that. We were the leading enrolling site for the sister study nationally. And so that's something we're very proud of. That was a social intervention study for African-American women with endometrial cancer. And it was looking at 3 different ways of supporting women through that diagnosis. It was a very, very pragmatic study with the outcome of being, did they get through the cancer treatment that was prescribed? And so we were very, very excited about that study. And then we have our LSU GYN Oncology Fund, which we use to support patients. So I have a patient right now today who's getting chemotherapy, who's using these funds. And essentially, we have a number of patients that can only get care with my group where we practice just based on their insurance situation. And it's really hard to have to travel for 4 or 5 hours every time you need treatment. And so we can set them up in a hotel, or we can help them with costs, especially if they're doing something brave like enrolling on a clinical trial. We want to support them as much as we can, so it's not a big financial burden, because they're usually strapped. As we all know, cancer is expensive. And we usually have a TLT to fundraise for this. So save the date, September 16th. So I'd like to thank my team. So I work with, 2 fabulous UN oncologists. I have some wonderful nurses like Beth sitting in the audience, and Krishana, and then 2 fabulous APPs that work with us. Our brave patients, of course, because none of this is possible without them taking a risk and going on these trials, and we learned so much from them. CAGLA, because I do think I've rarely been part of an organization that was so good at crossing the different institutions. It's very collaborative. The Al Copeland Foundation has been extremely supportive of our work, my LSU colleagues and faculty, LCMC for their vision, and then the New Orleans and Louisiana GYN cancer community, as well as my family, because they put up with me. And that's it. These are my references. Questions?